Hi, I'm Dr. Peter Duffy. I'm the Director of the Cardiovascular Service Line at Reed Heart Center, First Health of the Carolinas in Pinehurst, North Carolina, and an active interventional cardiologist. I'm also on the Board of Trustees at SCAI. Many of us have been challenged over the years to improve the quality that we provide our patients. And that's been a daunting task in some cases because we really can't all agree on a uniform definition of quality. Moreover, recently we've also been challenged with healthcare reform, and in many cases we've been put on a defensive position to be able to justify what it is we do, why we do it, and why the costs of what we do are so high. So in thinking about that, it became difficult to really create one uniform definition of quality. But I think if you really look at it, the Institute of Medicine has a really good thought, and that's to take ingredients and put the ingredients together, create a recipe, and create a recipe for success. And I think we as interventional cardiologists can do that. So the 6 parameters that the Institute of Medicine uses are care that's effective, efficient, equitable, patient-centered, safe, and timely. But that's hard to put together on a daily basis, think about each and every patient. It's also hard to put together when you want to really show the value you're creating for each patient every time you take care of someone. What I've done is put those 6 parameters together and distill them down really to 4 basic principles. And that's the principles of appropriateness, number 1, and clinically derived outcomes, number 2, patient-centered outcomes, number 3, and resource utilization, number 4. When we put those together, think about it as care that's appropriate, think about it as patient-centered outcomes. What did the patient expect to get from the procedure or the test? Did they fully understand the risks, the options, and what was really going to happen to them? What did we expect to have happen clinically? Did we get the desired result? And lastly, resource utilization. Did we use the resources that we have, which are finite, in an efficient way? It puts together those 4 parameters in a relative way that I think make it useful for us to think about it and can really create a way for us to be proactive and not defensive about healthcare reform and our value to our patients and to the healthcare system. So the question really is, how do we use the appropriate use criteria and how that intersect with the real value formula? And really what we're doing with the real value formula is building upon the appropriate use criteria. What I think we can all agree on is that usually appropriate use criteria is, to use the word, appropriate for a given patient. But on some occasions it really isn't. And there are many examples which we can all cite in everyday practice where we could have, by the letter of the law, used the appropriate use criteria to do something for a patient, but really for that patient it probably wasn't the right thing to do. And we can also cite examples where in other cases where for patients it really was deemed inappropriate by the appropriate use criteria, it really was the appropriate thing to do. One of the things we have to remember is appropriate use criteria doesn't take into factors such as age, patient wishes, patient activity levels, whether they're able to take medications, those sorts of things. So we really want to use the real value formula to build on appropriateness. And we want to start with appropriateness, and if we don't meet the appropriate use criteria, we want to know why, but it doesn't mean we shouldn't do it. But also, if it does meet appropriate use criteria, it also doesn't mean we absolutely should do it. So it builds on the appropriateness by adding into it, what do the patients expect, what did we expect as clinicians, and what resources were utilized in order to get that result. The real value formula came about from my looking at the value equation, which is value equals quality over cost. And really it's hard to implement that on a regular basis when you're talking to patients and working with an individual patient. For one thing, quality has a myriad of definitions, and it's really in many cases in the eye of the beholder. So I thought we needed something a little more specific than that. So I broke quality down into what I thought were patient-centered outcomes and I thought were clinically derived outcomes. And then divided that not by cost necessarily, but resource utilization, because it's not actually just dollars that we're looking at here. It's opportunity costs. We could have been doing something else instead of doing a procedure that may or may not have been appropriate to do. We've got ancillary staff. We've got families that are taking time off to be with loved ones while we're doing procedures. How necessary is it to get the procedure done to bring somebody else in, to have them take a day off to be able to do something for that if the procedure really isn't going to benefit the patient? So those are the kinds of things I really looked at, and the real value formula came about just by me trying to create a practical way to integrate the 6 parameters from the Institutes of Medicine, as I mentioned before, and be able to use them not only in taking care of an individual patient, but in setting up care pathways, and even in many ways setting up how we set up healthcare systems to take care of patient populations. As interventional cardiologists, we have a proven track record of leadership in developing care pathways, appropriate use criteria, and really providing value for our patients. But unfortunately, we're often put on the defensive to show what that value is, and oftentimes our systems are not set up to really prove that value. The other thing, too, is I really think we all want to improve quality, but as I mentioned before, with the 6 pillars the Institute of Medicine has, it's hard to figure how to put that into practice with every patient. So what I really want to have the real value equation do for us is give us a way to think about this when we approach patients, not just from a interventional standpoint, but even a testing and total care standpoint. What is the appropriate thing to do? What do we expect to get out of it? What does the patient expect to have happen? And how much resource utilization was required to get that kind of result? So really, to me, it's a way to put quality into practice on a daily basis where we can just be thinking about that. I think we do think about it to some degree to start with, but not in that kind of a formal structure. The real value formula allows us to create that more formal structure. And most of us in interventional cardiology have pretty structured, logical, linear thinking minds to start with there. So really, I think the formula helps us really codify some of the things we've been doing, give structure to it, and I think that in the long run will again show our ability to be leaders in healthcare reform, because that really is going to change healthcare if we put those principles into practice. So I'd invite you to review the paper. It's attached to this video. It'll be published in CCI. It's available on the SCAI website through the publications area there, and it'll be published in print in the journal within the next month. I invite your feedback. I would really enjoy hearing your comments on it, how we can improve it, and how we can go about, again, reforming healthcare and being proactive rather than reactive. Again, my email is pld@nc.rr.com, and I welcome any comments and thoughts that you have. Thank you very much.